I'd like to welcome Dr. Patel, the always nicely dressed Dr. Patel. He's going to educate us on all the new and upcoming treatments so you know it's available. Then Dr. Hinkle will come back, talk about dementia and hallucinations, and then Dr. Patel will follow Dr. Hinkle and talk about non-motor symptoms and therapy treatment. And hopefully we'll all do-si-do in the middle here. All right. Please welcome Dr. Patel.
Good morning. Wow, it's bright. All right. So my talk for the next 20 minutes or so is going to focus on the new medications that have just recently come out, primarily looking at three main ones, including the two pumps. You guys may have heard things about them outside. So we're going to go into a little bit more detail about those, and then a new drug that should hopefully come out towards the end of the year, if not the beginning of next year, and then kind of a quick overview on more trials that are still in development for symptom control, specifically for Parkinson's. You guys, if I move like this, can you still hear me? Is that okay? Okay. So Vylev is the first one. Vylev is the 24-hour carbidopa-levodopa infusion. It is subcutaneous, so it's just right under your skin, like right around your belly button, around here. And it's to give patients that constant level of levodopa in your system. We know with disease progression with Parkinson's that patients have fluctuations in their systems, in their symptoms. They take medications, oral medications every few hours, and the meds just don't last the whole time. And so is there something available that could give you just that constant level, including all night long? And so that when patients wake up in the morning, or you wake up in the middle of the night to go to the bathroom or whatnot, you don't feel like you're slow and stiff and you can't do it. So that's where this drug comes into play. It is a pump, so similar concept. Diabetics need insulin pumps. Parkinson patients need levodopa pumps. And so that's what this is. You have a pump. It's about the size of two cell phones sort of put together. And you carry that around, so it's not small per se. And studies did show that patients who were on it compared to patients who were on oral medications, they had 2 hours of less off time compared to people who are on oral pills. In addition to that, had 2 hours of more on time without dyskinesia. So they were just much more smoother throughout the day, including overnight, feeling much better. Recently, they're showing, and what I've noticed in my patients anecdotally, that they're sleeping better. You would think that, I've had this pump overnight, I'm connected to it. Am I really getting good sleep or not? You'd be nervous about it, but in actuality, patients feel that they're actually sleeping better with the pump just because they're not waking up from turning off or feeling that they're feeling stiff or whatnot. So it's definitely very advantageous, and so far has been pretty successful. It is three main settings. So essentially, you come to the office, we set you up, they show you how to connect yourself with the pump. There's your base rate that you stay on consistently. You could switch over to a low setting. For example, say overnight, you don't need as much, whatnot, you could switch over to that. And then if you feel it's not really doing the trick, you want to go to a higher rate. So there are three main rates that we program for you in the clinic, and then you could toggle between those three rates. If at any point you do feel like you are turning off, you could give yourself an extra dose to kind of boost you up a little bit. And then if for any reason you're disconnected for more than 3 hours or so, there's a loading dose option that you could give yourself to kind of get you going so that you're not so off. Other things that have I'm going to give you the positives and the negatives to it. So I told you about positive. Good sleep. Patients are definitely smoother throughout the day. They like the idea of not having to be dependent on pills. and oral pills, and they're just, they're connected. That's it. They don't need to take any other Parkinson meds. This replaces all of that. There is risk for, you have to make sure you're judicious about keeping it clean, because you are poking yourself, so there's a skin infection risk. And sometimes the drug, depending on the needle, how deep it is, the drug may pool and kind of stay under the skin, and you're going to get concerned whether that drug's actually getting in their system. So those sort of things, which we've found different ways to navigate around it to help patients kind of overcome that. So that has been around in Europe for quite some time, and as of now is available in the United States. OnApgo is the other pump that also is now available as of the last couple of months. This one is different from Vyalev in the sense that Vyalev is carbidopa-levodopa. This one is apomorphine, which is a dopamine agonist. So for those of you who aren't familiar, dopamine agonists are a type of Parkinson medication. It mimics the brain to thinking that it's dopamine. It tricks the brain and acts on dopamine receptors to make it so that it gives you the same response that dopamine would give you without being dopamine itself. So this, compared to the other one, this is a 16-hour infusion, so it's just primarily during waking hours. It is a dopamine agonist, so it's not levodopa per se. And studies, when it was looked at in study purposes, patients did have 2.8 hours of more on time and about 2 hours of less off time without dyskinesia. So they had significant improvement. It is sort of a much smaller pump, and it is subcutaneous, just like the other one. So similarly, works in the same way. It has slightly different, more side effect profile just from the class of medication that it is. It is a dopamine agonist, so dopamine agonists by nature have a little bit of a different side effect profile than carbidopa-levodopa. You still get sleep, particularly the sleep attacks could be concerning. Impulse control disorder, you like doing certain things, shopping, eating, gambling once in a while, no big deal. But if you end up, gambling your life savings, that's a problem. And so things like that, where family members, we say, always kind of keep wary of. Dizziness, low blood pressure, those sort of things that we kind of always monitor for patients when they're on this type of drug. The idea is for it to replace medication, your oral medications. However, most patients are still taking their carbidopa-levodopa. Since this is not carbidopa-levodopa, this is a dopamine agonist, so patients would still likely need to still be on levodopa when they're on it. And it's not overnight, so in case you do need something overnight, then you would need medications overnight for that as well. But much smaller than the other one, and similarly is just under the skin. You can kind of put it in your pocket and not really think about it. So it's very convenient from that perspective. Crexont is the newer oral pill. If anybody's familiar with Rytary, which was a capsule of microbeads in the capsule that have immediate release carbidopa-levodopa and extended release carbidopa-levodopa. And so giving patients an overall more on time and decreasing their off time. You still have to take the pills 3-4 times a day, but it's just more consistent and you're smoother throughout the day. Crexont is the latest version of Rytary. It's a similar concept. There's just an extra coating in the capsule that allows for extra coverage and has been shown in studies to have even more on time and smoother for patients compared to oral carbidopa-levodopa and Rytary. So you can see here, whenever you take a pill and how quickly it goes into your system and how long it lasts in your system. So the black line, you can see that's just your oral immediate release carbidopa-levodopa kicks in, and then within 3-4 hours, you can see how it's starting to wear off. Rytary was there, and it showed it was lasting longer, and you could see with Crexont, with the extra coating, it kicks in even further, and you get more levodopa, and also then lasts even longer. You get 7-8 hours, at 6 to 8 hours, and so patients take it about 3 times a day. If you need it 4 times a day, you could take it 4 times a day as well. was shown. Again, you could see here, levels in the system was even more longer. Patients had, in 4.8 hours, the amount of levodopa was above 50% compared to patients who were just on the immediate release, and Rytary was 3.9, Crexont 4.8. So significantly more drug in your system that lasts longer throughout the day. So for patients, there's 3 different levels of dosing for it. In terms of insurance coverage, my personal opinion, although yes, you could start off straight to Crexont without being on levodopa, and they do say you could potentially do that. However, in reality, when insurance companies are sort of running the way we prescribe medications, you have to likely have been on immediate release carbidopa levodopa and even controlled release carbidopa levodopa before they're going to cover a medication like Crexont. But this would replace your oral pills, and especially for patients who are taking oral levodopa, 4 or 5 times a day and still feeling like they're wearing off, are not ready for some sort of device or surgery, then this is a good option where you may not need to take as many pills. You take it only 3 times a day or so, and it gives you that extended coverage. And then this tavapadone is the pill that is finishing up clinical trial currently, mainly at the Cleveland Clinic. It is similarly to ONAPGO, it is a dopamine agonist. However, it works in different dopamine receptors, where it was shown to have a better safety profile compared to the current dopamine agonists that are currently out there. It's a once-a-day pill. It was shown in 2 different trials. For the first trial focusing primarily on newly diagnosed patients who are not on any medications, and to potentially delay the need to be on levodopa. And it was successful in terms of a first-line agent, monotherapy, meaning just the only drug that you're on, to start off with to show improvement, as well as delay the need for levodopa. The next trial looked at how effective was it for patients who were already on levodopa, and did it make their symptoms also improve, which it was also shown to be successful. Not as good as the first trial, but in both instances was a successful drug, so it's currently under FDA review. So again, first generation dopamine agonist, it activates a different set. Our old dopamine agonists that we have right now, they work on a D2 receptor, which causes a slightly higher side effect profile. This one's a little bit different. It works on different receptors. So from that nature, it should potentially decrease the bad side effects we don't like the impulse control I talked about, the sleep attacks, weight gain, leg swelling, that kind of stuff. So this is targeting a different area to avoid some of that. And then real quick, we have time, so that's good. So in terms of studies, and what Dr. Hinkle touched on a little bit already, with Parkinson's, and we know Parkinson's, and everyone in this room is aware, every Parkinson patient's different. Parkinson's is not a cookie cutter disease. It is a very individual disease. And when we're doing research and trying to come up with potential novel agents and what next thing could be available, and the hurdles we come across, and when we do scientific research, especially with Parkinson's, first you start off in animal studies, and you have, mice or rats or whatnot, and they're all given Parkinson's. They're given a chemical that depletes the dopamine in their brain, and so they all get Parkinson's. And then they think, okay, well, this drug may be effective. Let's give it to the mice, and let's see what happens to them. And they get better. Excellent. Okay, now let's translate this to the human population. Well, all of you in this room did not take a chemical that gave you Parkinson's, right? Everyone's different. And so when we try to translate that into the human population, there is this loss in translation. And so unfortunately, we come across that hurdle of, what's actually going to be effective in the human population. And so that's a struggle we come across when we're trying to find studies, which is why there is so much research going into it. And so many different ideas is just because it's a heterogeneous population as a whole. In addition to that, there is no biomarker. There still isn't a confirmative you have this blood test to say you have this, so you have Parkinson's disease. And so when we don't have that, and we don't have markers we could do to monitor and see rate of progression of disease and things like that, it makes it a little bit of a challenge in terms of, well, how effective are these drugs, and are these drugs hitting the right patient population, and what are we doing? So those sort of things can make research in Parkinson's a little bit of a challenge, but we are hopefully overcoming that. There have been recent advances to show maybe that we can start monitoring for biomarkers, not for every Parkinson patient, but at least some Parkinson patients, but it gives us a headway, hey, there is something. In 2023, there were considerable advances in the biomarkers for Parkinson's disease, looking at alpha-synuclein levels in patients' cerebral spinal fluid, and we're able to now pick up on, okay, we know Parkinson's is associated with this particular protein, and we're picking up on elevated levels. Okay, hey, maybe this is starting to be a sign for Parkinson's, and we could start monitoring this. And once we could pick up on these levels, now we could apply that in terms of novel drugs and new drugs to say, hey, are we really targeting and are we hitting alpha-synuclein and affecting these levels, thereby changing the progression of this disease? And so being able to do that, can now, hopefully we're going to now be able to get to a new level in terms of advancing Parkinson's and the next level of treatments that are going to be available. In addition to that, they're looking at different dopamine dysfunction, like what other levels are there, whether enzymes can we monitor for it, not only in the blood in the cerebrospinal fluid, that could hopefully we could pick up on early PD and see, hey, there's levels of changing here. Hey, this could be an indication that this patient may not have a lot of symptoms right now, but that we're leaning towards the levels of Parkinson's, or Parkinson's may come to play. So the fact that these measuring tools are now coming into play, and we're going to be able to use these things now, hopefully we'll be able to take that to the next level for research purposes. So I mean, this is just a snapshot of, and Dr. Hinkle will be touching on this as well. But you can see here, this is just everything that's currently in the pipeline. There's so much happening, from disease modification, from symptom control trials. There are many, many, many trials going on right now in regards to Parkinson's and targeting many different areas within Parkinson's itself. From the symptoms control perspective alone, I can tell you there's just this paper was published in 2024, 76 symptom control trials that were being looked at least 30% of which were looking at dopamine replacement and dopamine modification, 43% targeting other neurotransmitters. We know Parkinson's is not just a dopamine problem. There are other neurotransmitters that are involved, which I'll get into more with the non-motor talk later on. But so many trials looking at what other adjunctive treatments are going on, stem cell treatment, looking at microbiome, anti-inflammatory things. So lots and lots of different things that are happening currently and all being looked at. So there's lots of stuff that are happening, and with the adjunct of picking up on biomarkers and stuff, I think we're going to make great headway in the near future, and it's a really exciting time from someone who helps treat patients that, hey, there's a lot more to come and a lot to look forward to. And that's the end of mine, and I will now throw it back to Dr. Hinkle. Thank you, guys.